Hi, this is Professor Butler, and these are your slides for your pediatric neurological care and conditions. In this lecture, we're going to go over from basically the neck up. In another lecture, we're going to go over stuff from neck down, as well as musculoskeletal conditions that are neurological in nature. So let's get started. So first we have here your lesson objectives. We have a lot to go over. I will have to say that I believe that the neuro lecture is the heaviest next to your respiratory and your GI. So this is something where we do have a lot of information to go over, and so this should be fun. And this is also one of my favorite topics to talk about as well. All right, so like I said, we are going to deal with, let me grab my pen too real quick so I have it in hand. I'll do pink today. So it's not working for me. Hold on. Well, we'll just use that one then. So like I said, we're going to talk from the neck up. We have here the cerebellum, the medulla, the pons, the midbrain, and the cerebrum. All right. We're also going to talk about some other structures that are deep within the cerebrum. And like I said, later on, we will be talking from basically the neck down, as well as the peripheral system and musculoskeletal. Okay, it's not working. Hold on. Oh, sorry, guys. All right. Okay, I got it working now. All right, so just as a review, we have white versus gray matter. And as you can see here on this slide, I have the definitions of white matter and gray matter for just as a quick review so that you can hear. It's white matter is the light tissue that shows up on a CT scan. You're going to hear me say CT scan more than MRI, but obviously we can do either or. There is some advantage of the CT scan versus MRI and back and like work otherwise. So white matter is light tissue of the brain and the spinal cord, consists of nerve fibers and myelin sheaths, controls involuntary functions like blood pressure, heart rate, and temperature, and sends sensory and motor impulses between the peripheral system and the gray matter. Whereas the gray matter is the dark tissue of the brain and spinal cord that consists of nerve cell bodies and branching dendrites. It controls hearing, feeling, seeing, speech, and memory. And it sends information received from the white matter out to the organs in the peripheral system. And so you see on the slide like a cross section of the whole cerebrum. And as you can see here, here's your gray matter and here's your white matter. And so when we're looking at a CT scan, we want to make sure we have a clear, defined vision of where you can see white matter, where you can see gray matter. If we see shifts, if we see where we can't really see where one starts and one ends, then that's not a good picture. And we'll go into more of that later because that's a sign that the person has possibly herniated. This other picture here just also shows gray matter and white matter because it goes all the way down our spinal cord. And this is the actual spinal cord. Again, we will talk more about that later on in another lecture. So moving on with our review, and the review will also be on the test, as well as obviously if I'm doing them on your pre-slide, you're going to have some questions related to the review that is on these slides only. But if you're really weak when it comes to the neurological system, you're more than welcome to go ahead and brush up on that by reading any type of material you already have on hand. So the meninges. So the meninges in the skull consists of the dura mater, the arachnoid, and the pia mater. So I want you to make sure you understand the different layers, and I think I'm in the way, but you can see on your own slides. So we have the skin, then we have a small layer of tissue in between the skin and the cranium, then we have the dura, the arachnoid matter, and the pia matter. And so sometimes when we get certain bleeds, for example, we'll talk later on, it's really important to know where that bleed is occurring, because that will tell us maybe what type of bleed it is and the source of the bleed, and then also how we're going to treat it. So in the cranium, obviously there's brain tissue, there's blood, there's veins, and there's CSF. There is a theory or doctrine called the Monroe-Kelly doctrine. It's spelled Monkelli, as you can see on your slide. And the Monroe-Kelly doctrine states that, as you may have learned prior, that 80% of the volume in the cranium is made up of basically brain tissue. The other 20% is CSF and blood. Okay, so this whole doctrine or this theory is that if there is a change in volume in one, there has to be a change in volume in the other. So let's just say if we had a bleed, if there was a brain bleed, then that means that either the CSF or the tissues and the structures in the cranium are going to have to decrease, because the cranium is a closed system per se. We have a little bit of a caveat with pediatrics, but the cranium is a closed system. And so if we do not have a decrease in one or the other, then that means that there is going to be some type of rupture, or we have to release the pressure, because the pressure will build up in the cranium because it has nowhere to go. So it can go down the spinal cord, but a lot of times, what you may have heard, people make bury holes, or they will take off a flap. They'll do a flap, and so that the brain has some place, some room to expand, because according to the Monroe-Kelly doctrine, that if we don't use these procedures, then they are going to suffer brain death. All right. Now, however, in pediatrics, we have fontanelles, which we're going to talk about in just a second. We have fontanelles, and because their cranium is not fully fused until later on in life, then they have actually the ability to expand if they have something going on that requires them to either drain or expand or whatever the case may be. So that doesn't mean that they're out of the woods and that they don't suffer brain damage or brain death. That just means that they have a little more wiggle room if their fontanelles have not fused. All right. That's so for example, think back when we were talking about dehydration. And you know how we talked about if they're dehydrated because we have a decreased volume, that you may see sunken fontanelles because they're dry. But in this situation now, when we have an increased pressure in the cranium, you're going to see bulging fontanelles. And so those bulging fontanelles are a sign that we have increased pressure, and basically what's happening is the brain is taking advantage of that extra little space. All right. So going back to meninges, the dura mater, in the dura mater, blood vessels do exist. In the arachnoid layer and space, this is where specifically the CSF flows. So we're going to talk about CSF more in a little bit. And in the pia mater, this is a membrane that covers and connects the cerebral cortex. And in this membrane, there's lots of arteries and veins. They're very rich. It's a very rich area for blood to be delivered and for bleeds to actually happen. That can be arterial bleed or venous bleed. All right, so let's go to our next slide. I have two computers up, so if you see me turning a lot, I apologize, but I just want to make sure that we are on the same. Okay, so for our cranial sutures, we have really four listed here. So basilar suture as well. You can't really see that one, but I'll explain where it's at. Lamboid, coronal, and sagittal. And then we have our fontanelles also listed here because we do have to consider the fontanelles when we are talking about pediatrics. So here's our anterior and our posterior fontanelles. And you can read about these sutures in your book. I just want to mention that your sagittal sutures are the ones that usually are fusing first. And then I will also want to mention that your basilar suture, the basilar area is right behind the ears. And so we'll talk a little bit more about that later when we talk about our fractures in a second. But those are, this is the area where usually if they still use forceps, this is the area that can be fractured in the basilar area because they're not fused. One, they're very sensitive. And two, if you've ever seen a forceps delivery, you will know exactly what I'm talking about. They pull right behind the ears, and it's very traumatizing sometimes. And it's actually a very dangerous fracture for an infant to have. So the lambdoid suture connects the parietal bone and the occipital bones, as you can see here. The coronal connects the frontal and the parietal bones, as you can see here. And I talked about the basilar and the sagittal suture basically connects the two parietal bones on the skull. Okay, so here are two parietal bones here, and that's our sagittal suture. So this is the one that usually fuses first, and then the other ones will fuse later on. So head injuries. Since we're talking about cranial, we're going to talk about some head injuries really quickly. So for our head injuries, we're going to talk about acceleration or deceleration injury. You talked about this in an earlier class, so I'm not going to spend a lot of time here either. So this is just a review. And then shearing injuries, concussions, and contusions. So forces that act on the head through acceleration or deceleration can cause like a shift in the volume of the brain. So, or the brain volume to shift. So, well, it can actually do both. But when we have a child or anybody, to be honest, as you can see here, if they hit their head, let's say on the dashboard, and they're not restrained properly in a car. So this is the injury of where impact happened. And then when you're thrust backward because of whiplash, or just simply because of the nature of the injury, it hits the countercoup, which is the area here in the back. So the brain shifts forward, and then there is a countercoup injury in the back. So we're going to see bruising occur over everywhere on the skull floor. So we're going to see usually a breakage in where we have our coop injury, and then we're also going to see some damage elsewhere on CT scan because of the countercoup injury. A shearing injury is caused by unequal movement of different rates of acceleration. Okay? So this can cause tearing of the arteries and results in possibly some hemorrhages, and it can cause some really deep cellular damage within the brain. And a typical thing that we see this is when somebody has shaken baby syndrome or shaken syndrome, or something that is so violently shaking them that they have a shift everywhere. So this is usually, again, unequal movement. So it's not just forward and back. It's usually they're shaking him like this, and they're like going like that, like a rag doll. And so this is called a shearing injury, and we can just see multiple injuries on CT scan. Concussion, as a review, is a brief disturbance of brain function that causes confusion and amnesia, but we can't see anything on CT scan for this particular injury. So we have to usually go off of a good history on what happened, then look at imaging, and then say, okay, we think you have a concussion, which I call the bruising brain bruise. Just because I talk to kids all the time, and I'm like, you have a little bruise on your head, so you have to take it easy. Contusions are actual lacerations or tearing of brain tissue, and you will be able to see this on CT scan, versus a concussion, you don't see it on a CT scan. All right. Next slide, we're going to talk about the fractures that I mentioned before. So we have different fractures. We have them listed here, and I'm going to go over them and then talk about some of the things in particular about the basilar fracture, because this is also an NCLEX one that they love to test you on. So linear fracture is just that. Linear fracture is a single fracture that does not cross the suture lines. So this is where you got to know your suture lines, and you have to know your descriptions. And so if something has crossed the suture lines, or if something has not crossed the suture lines, that will indicate to us what kind of fracture or injury that has happened to this child. So again, linear fracture, single fracture that does not cross the suture line. A depressed fracture is just like that. It's a depressed fracture. And I believe that's on, it's on your image here, right here. So that means that there's something blunt that hit the head and has caused bone fragments to actually enter into the skull. So they have to usually go in to pull out those fragments and get a surgical repair of the cranium. Community fracture is multiple linear fractures, okay, and is very highly suspicious of child abuse. So that means that there's multiple linear fractures that we see. They could also be at different stages of healing as well. So I'm going to come back to basilar in just a second. Then we're going to talk about open fracture. It's a fracture that's not depressed, but it is open. And the danger of this, obviously, is because they're at more risk for infection. And so this fracture is open. It communicates to the scalp and also internal structures. And so that is a big, big issue. Growing fracture, is an old fracture that has not healed properly. And it ends up being reopened because of some type of injury or something that's going on. And so this fracture has resurfaced or reopened. So going back to our basilar fracture here, this is here the area behind the ear that I was talking about. Basilar fractures are at the base of the skull, and they involve the dura. This can be very serious because it's located also near the brainstem. Whenever we have issues that are dealing with the brainstem, we have to be very careful. Some of the manifestations that you'll see are raccoon eyes. Okay. You'll see bruising behind the ear, as you can see here. You also may see some drainage coming from their ears or from their nose. So if you see, and we can't, anytime a child has this type of injury, we have to be mindful that if we do see some drainage, it's not just to have a runny nose. We have to use glucose sticks to test that drainage because they actually could be leaking CSF. And that tells us that there is some type of opening, and that puts them at more risk. So the glucose sticks here is just to remind you that if you see some images like this or you hear history of that, then we need to test it. The redness that you see is, basically it's something has hit or something has done some trauma to the mastoid process. That's right behind the ear. It can resolve itself, but we need to make sure that they don't have any sequelae. And just to really quickly mention the bruising on the eyes, the sign is called the battle sign. That the child has not been in a fight, but it looks like they've been at battle with somebody. So that's why they call it the battle sign. All right, so those are your skull fractures. Now we're going to go into hemorrhages. So we're going to talk about 3 of them. There's another one we're going to talk about in class that we typically do see. Typically do see with children. It's not a good one, but we'll talk about it in class. So epidural, subdural, and IVHs. IVHs are specific to our neonatal population. So let's see, epidural. So an epidural bleed, and I think we have an epidural bleed on here. Yes, here's an epidural bleed. The bleed is between the dura and the skull. So remember when we talked about the meninges? So this is, again, referring back to that slide just so that you have a visual of where I'm talking about, where the bleeding is occurring. All right, so it's between the dura and the skull, and the brain becomes compressed. Again, Monroe Kelly. because blood accumulates pretty fast, because an epidural bleed is an arterial bleed. Okay. And they can have periods of unconsciousness and lucid periods. So 1 minute they're fine, next minute they're acting weird. The severity of it depends on the size of the bleed. And then as the brain becomes more and more compressed, you're going to start to see, depending on where the bleed is, you're going to start to see some serious signs and symptoms that are indicated in that particular area. So this can become an emergency. These usually are very acute. We get reports that they fell or they got hit or something happened. And let's say it's around 12 p.m. in the afternoon. And then literally within an hour or two, we're starting to see these signs and symptoms. This is different when you're talking about a subdural bleed. A subdural bleed happens between the dura and the arachnoid space. And the subdural hematomas are more common than epidural. And this is a venous bleed. These happen more frequently in infants due to birth traumas or assaults or non-accidental traumas. And again, these type of bleeds is a venous bleed, and they are also slower. Okay, these are very slower. So it could be, again, using the same scenario, it's 12 p.m. and then eventually it gets to like around maybe 6, 7, 8 o'clock, and like they're just not acting right. So these are very slow bleeders, and then all of a sudden they start to have different changes in their level of consciousness. They will be complaining of a headache because the cranial pressure is increasing and the brain doesn't have anywhere to go, depending on the child, because it could be a younger child where the fontanelles have not fused, and then they may end up start seeing some weird, their cranium, their head starting to look really weird. IVHs are, like I said, particular to our neonatal population. These are called intraventricular hemorrhages, and they're due to the immature vascular development of their brain, and their brain is very sensitive to any intervention, sound, disturbances, because remember, this baby's supposed to be in utero, and if they're born prematurely, all these different things that the brain is trying to process is not protected by being in the womb. So we use a bedside ultrasound to monitor for children who are born premature, just to make sure that they're not having IVHs, because it's really hard to tell when they are unless we see some increased swelling. And we grade these from a type 1 to a type 4. So they go from grade 1 IVHs to grade 4. And we do this by ultrasound, but also at the bedside, the nurses are responsible for getting a daily head circumference. So we will measure their head circumferences and compare it and put it on a graph. And then that's actually something that we do report off in the NICU. If you're really in a really good NICU, then we will see these trends to make sure that we're not having if this increase in their measurements is normal growth, or could we possibly be having an IVH. There's nothing we can do about IVHs. So if a child gets an IVH, it can resolve by reabsorbing, or just they're dealing with it normally through growth. But because children's brains are very resilient, they're not like the adult brain. And we'll talk a little bit, touch on that here and there, and a little bit more, both in class and here in just a second. So if they don't resolve on their own, yes, they're going to have some issues later on. But this is something that we're not really going to be able to see the full effect of it until they, start to go to school, see different things. It could actually affect, their vision, their hearing. So again, it depends on where the bleed is located. But to be honest, there's nothing we can do but try to keep it quiet, minimize our interventions, cluster care, to prevent them from getting IVHs. The more premature a child is, the more chances of them getting at least an IVH. But you don't want, if they're going to get an IVH, you want it to be grade 1, because grade 4 is the worst. And usually if they have grade 4 bleeds, then they're going to have some issues later on cognitively. All right, so let's move on to our next one. We're going to talk about those hematomas. And I want you to actually, I think this is an image. I want to jump to the next slide first to show you this, because these kind of go together. So I want you to focus on these two, the caput and then the cephalohematoma. Those are the two I want you to look at, because on the previous slide, they talk about the epidural and subgaleal hematoma, but we kind of already talked about that. I only want you to really focus on the two I just mentioned. So this image here that you see, don't pay attention to these figures. These are from a different book. But this is also, again, we're looking at one, did it cross the suture line? And so we all know what a hematoma is. We all know here the causes, some of the characteristics. And I remember watching a video recently, and somebody was just stroking this baby's hematoma, and the baby was like, ah, and I was just like, stop touching it. That actually hurts. And people, every time they see it, they feel like they just need to mold the head back into, like they're helping the child when actually you're hurting the child. And so I just want to make that point real quick. It's like one of my biggest pet peeves. It's like, if you had that on your head, you would not want anybody to touch it. So stop touching that baby's hematoma. Anyway, so this slide here talks about the two different descriptions, and I'm keeping it from a different textbook because I love how it basically breaks it down, and I want you to make sure you pay attention to this. So anyhow, these will resolve. There are some caveats to this, and I'm going to focus more on the things that we need to focus on the cephalhematomas. Again, the caputs, this is usually healed spontaneously within a few days. We'll just have to monitor the child. The bilirubin, in particularly, these children probably will need some phototherapy because they probably will become jaundiced, because the immature liver has to handle all this additional breakdown of red blood cells. And when it does that, the child becomes jaundiced, but it will resolve naturally. All right. And so as you can see here, this crosses the suture line, the sagittal suture line, which is between the two parietal bones. All right. So this is not necessarily a big deal. So when we're palpating, when we're assessing to see if it crosses the suture line, if I see that it does, I'm like, whew, that's good. This is usually due to a vacuum extraction, and you guys know how many pop-offs that are allowed. And so if OB person is doing a C-section and they do 4 pop-offs, and we hear that in report, we're a little bit concerned, because you're not supposed to do, we're not supposed to do any more than 2 pop-offs. Okay. All right. So then let's talk about the cephalohematoma. So the cephalohematoma it does not cross the suture lines. All right. It's a collection of blood from the skull bone, and it's located, let me see if I get this right. I don't want to tell you it right. I want to say it's in between the dura and the pia, if I'm correct. And they're going to be anemic, because this is one that it's accumulating, and it's not going to stop accumulating until we go in and fix it. So usually they evacuate the blood. The child will start to show signs of hypovolemic shock, but this is a hemorrhage one, right? Because they're bleeding, and rarely leads to an infection. But it can, because like I said, it's at the lowest level, the pia level. and so they're at risk for infection. So anemia, hypotension, risk of shock, and also they are also going to be jaundice eventually as well. Okay. All right. So let's move on to our next one, and we're going to now jump into the brain, and we're going to review the cerebrum. So we have all these wonderful lobes. Don't freak out. I'm not going to test you on the lobes. The frontal lobe, the parietal lobe, the temporal lobe, and occipital lobe. All of a sudden I can say the word. All right. So, so the brain consists of all these four lobes, also the basal ganglia, the corpus callosum, which is in the middle, and then we have the limbic structure. So we're going to just talk about them really quickly. So the frontal lobe controls motor, speech, and writing. The temporal lobe, memory. Parietal lobe, processes touch and sensation. And this is really condensing it down. Occipital lobe, visual world and seeing, and corpus callosum, like I said, connects the two. All right. You need to know about the corpus callosum. I'm not necessarily going to test you on this. If you're going to be a neuro nurse, you probably would definitely want to know these in more details. But you do need to know we have four lobes, and we have these other wonderful structures as well. So here's a picture of the corpus callosum. Like I said, the area in between. Look at this wonderful differentiation of gray and white matter. And then we have all these, here is your cerebellum, and then here is going into your brainstem. Okay. All right, so basal ganglia. Oops. My thing is not working, guys. Okay, there we go. So we have some structures that I want you to review. The thalamus is definitely one. In general, the basal ganglia is a group of nuclear structures located in the brain that receives information from the cerebral cortex and plays a role in motor function. All right. It is located deep in the cerebral hemisphere and is a vital role in voluntary and involuntary movements. All right. So that's all I want you to know about that. And if I want you to know about it, it's because if you hear that there is damage to the basal ganglia, then you know that we're probably going to have an issue with voluntary and involuntary movement issues with the child. So that also could be balance as well. I'm trying to think, there's one more. Maybe I'm getting ahead of myself. Let's keep going. So make sure you review the basal ganglia, thalamus, and you know that it plays a vital role in involuntary movement and voluntary movement. All right, so limbic. Oh, this is the one I'm thinking about. So the limbic system, this is where I want you to focus specifically on the hippocampus, which affects memory, and the hypothalamus. We know what the hypothalamus does, right? But in particularly not just about our hormone release to our anterior and posterior pituitary gland, but it also regulates temperature stabilization. All right. So anybody who has an issue or disturbance to their hypothalamus, they're not only going to have hormone issues, but they're going to probably have issues with regulating their own body temperature. All right. So these structures, these are all, again, deep in the brain, not trying to go too deep here. Hippocampus, of course, like I said, is about memory. And, this whole area has a lot to do with emotions and behaviors. So if a child had some issues in this area, and then they ended up being misdiagnosed or diagnosed with a lot of behavioral issues, this would make my eyebrows go up and be like, I wonder if they had any issues in their limbic system. All right, so let's go to our next slide. This one you are going to need to know. So a ventricular system is majorly deals with our CSF. So there's 4 ventricles. And the ventricular system, carotid plexus, carotid plexus is the structure that produces CSF, versus the ventricles are the ones that actually hold and release CSF in the system when necessary. Remember, I said that the arachnoid space is the space where mostly CSF flows, right? All right, so before we move forward, I want you to understand the function of CSF, because usually a lot of students don't know this. CSF has many roles. One, it cushions the brain, right? It cushions the brain. It provides nutrients to the brain. It also basically removes waste as well. There is a specific thing about the CSF system, the ventricular system, is that it does not cross the blood-brain barrier. So there is no mixing of blood and CSF. All right. So if that happens, we got a problem. But it has those wonderful functions, and if CSF isn't flowing, then the brain isn't going to be cushioned properly. It's not going to get proper nutrients, and it's not going to be able to remove waste. As well as if there's a buildup of CSF, then again, the Monroe-Kelly thing, you're going to have a decrease in another. Or later on, when we talk about hydrocephalus and so forth, we talk about the devices that we use and how do we manage those children who are living with hydrocephalus. All right. So also with CSF, newborns produce about 1 milliliter per hour of CSF. All right. This is something that's produced all the time. And again, if I'm going to say it right, carotid plexus is where it's produced. Whereas adults usually produce around 30 cc's, 30 milliliters per hour of CSF. So this is something that's continuously going on in our body. And the total amount in the system varies with age, but again, it is a constant flowing and production system in our nervous system. All right, so I talked about how it moves through the arachnoid space. I talked about the functions. I talked about the amount, just to give you some FYI on that. And then let's talk about the actual arachnoid space. So in that space and how it moves are through villi. And these like finger-like projections, kind of similar to the villi that are lining in our intestine. They act as a one-way valve. And this prevents CSF from being mixed with blood. All right. So if we have damage to the arachnoid space, or we have high pressures in the brain for whatever reason, then the villi are usually damaged, and it can result in more absorption at some point, a stopping of absorption, right? Or again, we can have blood in the arachnoid space. So high pressures within the brain can result in more absorption to a certain point, and then high venous pressure can impede its absorption. Okay, so think about that. So high pressures in the brain can result in more absorption, and then high venous pressure can impede absorption as well. Okay. All right, so let me see if there's anything on my thing. Nope. Let's move on to the next slide. And then we're going to talk about our brainstem. So the brainstem includes your midbrain, your pons, your medulla, your reticular formation, and your cerebellum. Here's what I wanted you to know about the brainstem. It connects all of the CNS structures to the spinal cord. It is where all the 12 cranial nerves are located and connected. And the reticular function are gray matter within the brainstem, and they send information for alertness and consciousness. This is also where our autonomic system is located. And it also controls body functions like breathing, swallowing, and our main I just said autonomic stuff. So if you have injury to your brainstem, that means that you are probably not going to be able to breathe on your own. All right. So I'm not going to go through all of these things here. You can review them on your own. I want you to really know that the brainstem is the area where you definitely don't want damage to be done. Okay. Or in some cases, depending on, how you feel about this, some people say, if I'm not going to be able to do X, Y, and Z in my life, I would prefer for my brainstem to be injured, because therefore we know that, we're going to say that you're brain dead, and then you will have the chance to come off of life support. Of course, if you have damage to this area, we're going to have to breathe for you, and usually get a trach and so forth. So this is a very important area. Usually when we're talking about things, we want to know whether or not the brainstem is affected. All right, so now done with this one, and let's go ahead into neurological interview. Done with the review. So a focused neurological interview, basically we want to look at their behavior. Are there any weird movements? What is their level of consciousness? Are there any complaints of headaches, vision changes if they can tell you, strabismus that wasn't already there? Is there any history of seizures? Any recent falls or traumas? If it's a newborn, if we can get our hands on the APGAR scores, or usually they don't know what that is. If you're asking the parents, I would say, did they stay in the NICU for a little bit? Was it a normal? When did you guys take your baby home? And if they say, yeah, it took us about 2 weeks to go home, he or she had to stay, then that kind of gives me an idea that we need to get those records, because there is something prompting the need for the child to stay for longer than normal. Any family neurological history would be good, especially if we see something that could be genetic related, and any medications that mom is on if she's breastfeeding, and of course if the child is on. If a child is either seizing or in some type of neurological shock, you definitely want to ask if they've had any fevers, if there's any recent changes in school. That's something you can add to that. And then, of course, doing your own quick neurological assessment. And neurological assessment consists of mostly this. I already talked about level of consciousness, their posture, pupil response, which we'll go into that in just a second, and all the things listed here. I'm going to jump down to ICP versus CPP. And we usually like for our ICPs to be less than 20. Make sure you write that down. And then you do need to calculate your CPP. You need the map of your blood pressure. So your CPP is determined by your ICPs minus your map. And CPPs, usually we want them between 40 and 60. And it's in millimeters per pressure, so mmHg. And that is usually shows us that there's good perfusion happening in the brain, and the brain is getting oxygen. Okay, and in ICPs less than 20. Anything above that, it tells us that there is an increase in pressure, and that we have at risk for herniation or brain injury. And you will need to calculate that on the test. All right, so assessing level of consciousness. Obviously, we want to look if they're alert. In an infant, that looks different, totally different than if you're trying to assess the alertness of a 12-year-old, right? So, we want to know if they're alert and if they are able to understand and respond. So we're not going to for an infant, able to understand and respond is if they cry because I pinched their finger, or that is an appropriate response. Or if I come near them and they are grabbing onto mommy or daddy, that is an appropriate response. Versus a 12-year-old, I would do this a little different. Can you tell me where you go to school? Can you tell me where you're at? Or who's that on that board? If I have a picture of a dog or a cat, are they able to tell me something from a cognitive standpoint from where they are? So you have to be careful about your questions on how you would assess alertness. So again, consciousness looks at whether they're alert, are they awake, are they easily arousable, and if they're able to cognitively understand and respond to whatever you choose to do that's age appropriate. So being unconsciousness demonstrates a depressed cerebral function. Okay, if a person is unable to be aroused, then they are considered to be in a coma. All right. So we use a Glasgow coma scale, and we do have a modified one. Let me show you. So I will not test you on this scale, but I will test you as far as your interpretation of a reported. The Glasgow coma scale is used to tell us whether or not where the child lays on consciousness, and if they are 8 or less, we have to intubate. If it's 8, we intubate. So just remember that. Also, we haven't talked about spine yet, but you need C5 to stay alive. Those are 2 things you must know. C5 to stay alive, and if it's 8 or less, then we intubate. So if I say a child's Glasgow coma scale ends up being, okay, let's just say they respond to pain only, and it's a 10-year-old. They they're talking to, and then we have withdrawals to pain. So then that's a 4, right? So I said 2, 2, 4. So they withdraw in response to pain, but they're not localizing any painful stimuli. That's 4. So that's 8. So they might intubate this patient. So we have to be careful. If it's 9 or above, then they'll just continue to monitor and do very, very frequent neurological checks. It could be every 30 minutes. It could be every hour, depending on their score. All right. And let's see here. So now let's talk about something else. Posturing. So as you can see here, you have A and you have B, decorticate and decerebate posturing. So decorticate posturing is a flex. As you see, the child is flexed. Their arms are in, their legs and their feet are pointed. This is seen when there's damage to the cerebrum or cerebral cortex, and there's damage above that brainstem that we talked about before. So if you have damage above the brainstem, again, we're not going to necessarily, that tells us that you are able to breathe on your own. It's not as bad. However, decerebate posturing is an extension. And the way that we are taught to kind of try to decipher between the two is decerebate. As you can see the child here, this is an extension posturing. And it's a dysfunction at the midbrain or at the brainstem. And so so this is extension, and we say that these are wings. So if you can see my hands a little bit, I know my background is blurred, but we say that these are angel wings and they're trying to go to heaven. And so that's how we know that that's the bad one. So when we see, first of all, posturing in itself is bad. So any posturing is bad. We do not like to see posturing whatsoever, but if we do see posturing, decorticate is the better one. Decerebate is the one that's the bad one because it's at or below the brainstem. And then as we wind down, we're going to look at some pupils here, and we could talk about them more in class if necessary, but pupils tell us a lot. We assess pupils all the time. So you have here A to F, and dilated pupils, which you can see right, well, that's not dilated, hold on. Okay, C is dilated. So C is dilated. But before I go through these, I want to make sure you understand that we're looking at reactivity, or response. We're looking at the size, and you have to look at the size before you shine the light in. And you need to make sure you have a dark room in order to assess pupils. So if you flick on all the lights and everything, you're going to see the response to the light. But if you have the lights down, look at their pupils, size them, then take a light and shine it in, and you want to see the reactivity. We're looking at the reactivity of each eye, but we're also looking at that we want the same reaction in both eyes, right? And we're also looking at that the size is also going to be the same. So pupils equal and responsive to light, right? So that's Perla. And so that's definitely what we're going to be looking at. But there's also other things that pupils can do. So let's just kind of go through them real quickly. So this one, A, and I believe this is from your book. I believe so. And I'm looking specifically at the pupils. We do see some mitosis here, and you can probably see that, and that's a neurological eyelid issue, but it also can show some other things. But I'm mostly focused on the pupils. So A, I can't really see this one, so I'd have to lift up the eye, but just looking at this is a good pupil. If it responds to light equally, that would be okay. This one, however, C, I'm going to go down. C is these pupils are pretty large, right? So they're dilated. And that could be for different reasons. Not now. No, I've been talking about, death and dying and so forth. But this could be because this is a 16-year-old who came in with dilated pupils because they've been using substances, right? And so, of course, my question would be like, what did you take? What did you take, right? But it just also can be the reverse, where they can be constricted because they were taken, because different drugs do different effects on your pupil. So it could be poisoning also. A little one could come in that got into grandma's medicine or somebody's medication or into some substance, and so they're here for intoxication or poisoning. And so that could be why we have our pupils looking like this. Right after a seizure or on both sides of the brain, we could also see some differences in our pupils as well. All right, so let's go down. So look at this one. So look how big this one is and look how small this one is. So I haven't even checked reactivity to light yet. And so we already know that this pupil is, I would say this pupil is almost blown. It's getting there. And so, first of all, we have unequal pupils. Unequal pupils is an emergency. That's telling us that one side of the brain, which this is looking on the patient's left side, so the right side of the brain is affected. Something's going on. There's an increased pressure, there's bleed, there's something going on. They must go to a stat CT to figure out what's happening. All right. So, so we need to, unequal pupils is an emergency. And that's one of the reasons why we do frequent neurological checks, to make sure that our pupils are not becoming unequal. When my mom was hospitalized, and I don't know if you guys know, she had a stroke a long time ago. When she actually ended up having unequal pupils, they did tests, and then they put in a ventricular ostomy because she had unequal pupils, because the pressure was going really too high. All right. And so up here, this looks like very good pupils, right? So look at this one in comparison to these down here. So these are, I would say, almost pinpoint. Pinpoint pupils are a sign of sedation, drug abuse again, or poisoning. But it also could be a sign of brainstem dysfunction. So pinpoint you need a little bit more further investigation, just like I said, for the dilated pupils. And then here, I would say these are blown. So we have two equal blown pupils. That could be a sign of brain death. Okay. Another word that I say blown, it could be dilated and fixed. And when I say brain death, I'm talking about that herniation, or it also could be paralysis. And don't let anybody get you on this. It could be the person is blind. So somebody who is blind, their pupils are not going to react. So I've had a couple people get me on that, did tell me that in report. I go in and assess my pupils, and I'm like, and they're like, oh yeah, they're blind. They love to get the nurses. So don't let anybody get you on. So people who are blind, their pupils are not going to react, and that's what their pupils are going to look like. All right, we'll talk more about pupils later, but you do need to know these. All right, real quickly, we're going to talk about some diagnostic procedures. You do know about these. We're going to get into meningitis later. But, you know, laboratory tests, glucose levels. Glucose levels are very important in the neurological world. CBC's electrolytes, coagulation studies, especially if we think we have some bleeding going on. Blood cultures, if necessary, etc. CT scan versus MRI. And just to remind you, CT scans are mostly used in neurological, especially if we need to have a quick diagnostic imaging, because they're done like within 5 minutes, if not faster than that. And because we don't have time to wait, if we have to do interventions, we have to do them quickly. If we already know what's going on and we're just kind of just getting really good imaging to prepare for surgery, usually they will get an MRI. Oh my goodness. Sorry, guys. Click on the draw there. Okay, sorry about that. Lumbar puncture will check for meningitis. Obviously, we're checking for the CSF. If we do have that elevated ICPs above 20, we do not do a lumbar puncture because it can make the brainstem or the spinal cord herniate. EEGs, we are looking for seizure activity, and then X-ray obviously can be done also to look for skull fractures, and then looking at those suture lines. All right. I think we're going to stop here because I really, even though this is listed here, I want to talk in more depth about these last 3 slides before we go into neurological conditions. So we'll talk more about your bolts, your devices, because these are things, it's letting you know, these are devices that we do use at the bedside on a regular floor. And this is something that is routinely done. It's not in adults. In adults, it's very different. If you have this, according to Professor Hart, they go straight to the ICU. But in the pediatric world, it's like I said, this is one of the most common things, heavy things that we see in peds. Kids are always hitting their heads. They're always seizing, a whole bunch of stuff. So we deal with these on a regular basis, on a regular floor. They come to the ICU, well, of course, if we have more closer monitoring that's needed, or of course the severity is much higher. So I'm going to stop here at devices, and then we'll start here in class. Your quiz questions will be based on the ones that I've already dictated. If you have any questions about anything, please let me know.